Okay, hey, it's 2 minutes past the hour. A warm welcome on my behalf to the third FEMS meetup event. My name is Pekka Kahri. I am the interim coordinator of FEMS project, which is an EU-funded activity aiming to build a pediatric health data space. And today's topic is on the design of this pediatric health data space. And our speaker, Antti Kettunen, whom I will introduce in a minute, will be telling about this. I work at Helsinki University Hospital in Helsinki, Finland, and happy to host you here today. So with me there is Jonna Salminen, our project manager, and the supporting team also from Hospital Sant Joan de Déu in Barcelona. Welcome all. So for our series of meetups this autumn, we've already had two, where the first one was introducing towards the pediatric health data space, so what we're aiming at, and the second one, a technical presentation of what are federated data networks, which are the technical foundations of pediatric health data space and the FEMS project. Today we'll be talking about the conceptual design of PHDS, and we still have one more meetup coming during this autumn, which will be in the December 17th, Tuesday afternoon, 3 p.m. CET, where there is our first clinical use case presented. It's about benchmarking cardiology operations via federated data networks. If you have not seen our earlier meetups, so you find them in our YouTube channel, which you can find in YouTube, and also the materials that you will be shared guide you directly to the YouTube if you're interested. The rationale behind FEMS is around an urgent need for data sharing in pediatrics. In pediatrics, we all know that there is a small number of complex pediatric patients or rare diseases per country, and where the data collaboration in a cross-border setting is increasingly difficult due to privacy and other constraints, we need solutions to help doing research, develop new therapies, and improve patient outcomes in the field of pediatrics and rare diseases. Also, if we want to make assessment of effectiveness of new therapies, we need to accumulate data from various sources. If we want to develop AI applications and validate them and bring them into the market, we need to engage with medtech industry and innovation ecosystems, and the need for data is there obvious. And even for clinical improvement and benchmarking, many countries only have one or two children's hospitals, and often the most demanding pediatric care is centralized into a single institution in a country, which means that then finding peers for benchmarking and quality improvement within the country is increasingly difficult, so we have to work cross-border. And this is why we have set up FEMS project, which is a EU-funded and UKRI-funded initiative started October last year. We are 14 partners. We've been funded 7 million euros through Horizon Europe and UK Research and Innovation Agency, and we will be running for 3 years with hospital partners, including HUS, Sant Joan de Déu, GOSH in London, Erasmus Sophia Children's Hospital in Rotterdam, Mayo Children's Hospital in Florence, and Children's University Hospital Latvia in Riga, and also the collaborative organization of ECHO, which is the European Children's Hospital Organization, a non-profit association. Then we have technical partners, Veil.ai, a Finnish SME, Tietoevry, an IT service provider, and Aridia, a Scottish provider of research environments and research solutions, and then two business and professional services partners, Genesis Biomed and The Hive. Our speaker today is Antti Kettunen. Antti is the digital ecosystem and digital identity consultant at Tietoevry, Create in Finland. He's been leading one of our core tasks in FEMS, which is about designing the ecosystem architecture a key document for how we are building conceptually the pediatric health data space. And he's been leading much of our groundbreaking work here. And I would like to now give the floor to Antti for his presentation. And as always, after the presentation, we will enable the microphones and cameras also for the participants, and we will have an interactive session after this. But Antti, now the floor is yours.
Thank you so much. And keep in mind, even though the picture is a little bit different, even with all the hair, new hair, I'm still the same person there. So I'm really, thank you, Pekka. I'm happy to present the FEMS and the PhDs to you. Let me just open the PowerPoint Live. Really good to see a lot of familiar names in the audience. So welcome. It's really great to have you. I'm actually showing the wrong deck. So let me redo the sharing just to make sure that we get the latest and greatest version. Wonderful. Now we have the correct one. So, so we have about 30 minutes time
to discuss. We don't
see
the share yet. Antti.
Oh, you don't
see
the
yet. Share. Yep. No.
Now, okay, very good. So, so we would have a lot of things that we could talk today. So during the next 30 minutes, I will go over a lot of things. So it means essentially that we can't go too deep into many of the designs, but I'll try to make sure that we can cover all the important topics. I will go through first and foremost the challenges we're solving. You already heard some from Pekka earlier, some of our design principles. I'm going to give you a rough overview on what is actually contained in our designs, the business, the technology layers, and the governance layers. What are the key features of our data space and how the governance architecture is built, and in general, just how this works, how we're using the different components in our ecosystem data space. And then we're going to look also the trust model, which is really essential in this case on how we're implementing that, what type of layers there are, and finally have a brief look at the business. So all of these we could talk just another session itself. So let's hope that I'm able to provide you with the most important bits and pieces. So let's talk first about the secondary use of data. So there's a huge untapped value potential there. If you're in the space, you know this already, but if you're not, so essentially, let me just really briefly walk you through it. So hospitals essentially have these challenges in accessing useful and frequent clinical and operative benchmarking data. That's there's possibilities to do that. There are platforms that do that, but it's not just frequent and updated necessarily enough, or it takes up quite a bit of resources to do. And that's for hospital benchmarking, for the operative benchmarking, clinical benchmarking that Pekka mentioned as well. There's also a general need to speed up data permits and data permit processing times, and while doing that with a little bit lower cost of operation. So you can imagine that if you're doing any kind of research on healthcare data, so that essentially is a secondary use of healthcare data, you will need to apply for a permit, and that permit may take months of time to actually get approved. And if you need to do that in scale, like in the rare diseases use cases, you need to do that with multiple hospitals around Europe. You have a possibly really long processing times for that. So these are in general the kinds of problems that hospitals and the research research community is working and have challenges with. Some challenges that are in the current solutions or proposed solutions, there's a lot of regulatory requirements. There's the European Health Data Space Initiative, for example, the regulation that is just coming, which imposes new regulatory requirements. There's the unharmonized permit process. Each hospital has their own type of process, own type of permit templates for that. There's not much business models everywhere, so it's actually something that we're missing, is that how these actually are sustainable, because these are services that also hospitals need to provide, but it is a resource consuming operation. Then all the privacy and data interoperability challenges regarding healthcare data in general, and any kind of scalability. So far, the solutions haven't been really scalable enough while actually retaining the business sustainability. And many times these are also the operating costs in these kinds of systems may be actually quite high compared to the actual benefit that is got from this. So the PHDS, the pediatric health data space, as we call it, that's what we're doing in the FEMS program. It's a novel approach to solving all of this complexity around secondary use of data for benchmarking research purposes. And we're designing it, especially in the context of the rare disease research and other types of cases, obviously, where you want to do this in an international data collaboration. Like in our case, it's hospitals needing to exchange data between each other for benchmarking purposes, or that we have data users or researchers needing access to the or wanting to run some kind of research algorithms on data in international space. So what the PHDS does, it enables hospitals to engage in this kind of benchmarking activities and also engage in cross-border research projects with commercial or academic entities. We're designing it from the industry perspective. So we want to make sure that this is driven by hospitals, driven by the key players that are in the industry. But we want to make sure that it is also secure and it is private, but also that it has its own sustainability possibilities. And for that, we've done some design principles. And these are our sort of guiding principles when we design the whole thing, is that how do we achieve our goals? So these 5 principles are the efficiency. So essentially, we want to reduce the effort required for launching and conducting research or doing benchmarking. We want this to be obviously secure, that it is the highest security levels in terms of whether it's about accessing environments or exchanging information. We want to make sure that it's securely processed. It needs to be sustainable, especially economically. So it needs to have those business models that each and every party that participates has a model that they will actually see this with good benefits, with good incentives, and they wish to join that, and that creates as a perpetual type growth cycle. We want to also make sure that it is very scalable, so it can scale in multiple ways, whether that's in participants, like in hospitals, whether that's in use case, like the clinical use cases that we're talking about, or whether that's in the amount of transactions on how much it's being used. So this needs to make sure that it still scales, it doesn't break down, it doesn't cause continuous changes to other participants, but it's so that it's sort of growing with its usage. And possibly one of the most important things, because of the role of hospitals in this, is that control. So at every step, every point of time, because we are dealing with different countries, with different regulations for each country, with different policies for each hospital and data controller, it means that each of them also need to make sure that the control remains at their hands. And control over the data that they're the stewards of, and they have a legal liability to maintain certain level of security and privacy and control in that. So these are really, really key elements on our design in general. So next, let's look at the very, very high overview of everything. So it starts with the governance layer. So we need to think that this kind of data space always requires robust governance, and we have here. I'm going to open this a little bit later a bit more. We have a governance entity, which is used together by the participants to define rule books. We have our own governance model. We will define common policies regarding any kind of implementations, and any kind of agreements and contracts that are being set are defined in the governance layer. The operative network, or the technical layer, includes things like what kind of roles like our systems are in place. And you can see the bottom at the middle here, we have workspaces, we have shared services, we have federated node, and then we have things like policy definitions, identity wallets on the data user and hospital side. So we're going to open that a little bit more in next slides. In our data space, we're focusing on federated data processing. So it means that we're running federated analytics, we're running federated machine learning, and those things are the ones that we're doing. And I'm also going to be opening how this works. We're also, which is really important to understand, that we are not dealing with we're not dealing with raw patient data here. So everything that we do, everything we exchange, it's either anonymous synthetic data, it's either the results, for example, they're all aggregated data results, or they're machine learning model parameters, and every data that we actually process, so it needs to be anonymous. So we want to make sure that everything that is done here, there's no possibility to identify patients at any point of time during the execution in the database. So this is just to make sure that everybody understands that we're not exchanging patient data per se, or anything that can be identifiable to individual patients. We are making sure that it's something that we run different kinds of we can run different kinds of analytics and machine learning algorithms, but not expose the actual patient data outside. And the important part, obviously, is also the business that when we have the governance and technical operative network up and running, we are able to utilize different kinds of use cases in hospital benchmarking, in academic and commercial research. It could be also scalable to other types of use cases as well once that comes. But these are, especially the benchmarking, is something that we are really focused initially. And all the different types of business models that could be considered here, whether they are data licensing or access models or subscription models, these are part of the design as well. Then on the features. So in this picture, this is possibly, I'm trying to very, very simply describe the full ecosystem, the features and the layers, if you will. On the left side, you see that we have data users. Data users are the parties who want to access the data, to the researchers. They may even be hospital employees when they're doing benchmarking. Then we have a project workspace. Workspace is essentially a type of project management tool. It's not a research environment where you would access raw data and do analytics research types of things, but no, it's more about managing the actual research project within the data space. On the other side, you have a hospital, and hospital we call also data controllers. They can be also other types of data controls than hospitals, but at the moment, at least, we are starting with mainly hospitals. And the boxes here, you can see we have the identity and trust model, which is really critical on understanding how trust is formed, how identities are understood within this data space. We have a data exchange layer and a data discovery layer, and then 4 specific capabilities or features. The first one is the data availability. It means that the data, enables data users to discover what type of data is available through PHDS. And we use what's called OMOP. OMOP is a common data model used in this space. It's becoming widely popular, and we're using it to consolidate information, metadata, especially from the different hospitals, on what type of data they expose through PHDS to make available. Then is what was the data permit application. So when the researchers find what type of data they want to do research on and what kind of data they could request to be used in the research project, they will create a data permit application. So it enables data users to create a harmonized data permit application and use that to apply for a data permit concurrently from all the participating data controllers that could be able to provide data to their research. So this is really a key thing here, is that this is a process that has been done, that has taken so far months to do, whether to collect that information or to process that. And we want to make this really about shorter. So it's really about efficiency, making the data availability and the permit application process a lot faster and shorter than it currently is. Once the data permits are given by the hospitals, each hospital obviously will approve their own permit. So you will have multiple data permits for a project for each hospital, one for each hospital. You're able to run federated data processing. So this feature enables data users to provide a federated analytics algorithm or a machine learning algorithm that then can be executed using the federated node on the data controllers data. I will also open this in the next slides. And lastly, it's the results concatenation release. So because we have results from multiple data sources, you would want to get those data in and concatenate them and then safely and securely verify that they are anonymous and they can be released back to the data users as anonymous results of the data processing. Before I show how PhDs actually work, just so you understand, it's really important to understand the governance architecture. This is a little bit small picture, but I want to explain that the governance model is robust, and we want to make sure that it is based on strong contractual agreements. So we have the governance model and the common shared services that I mentioned and will be showing. They will be operated by a neutral governance entity. You can see here on the ecosystem governance entity. We have ecosystem members that are either full members or associated members. And you can see on the right side here, we have data controllers. So you can imagine these being hospitals. So if you're a hospital and come in as a data controller, you would sign a data controller agreement, agreeing to the ecosystem governance models and the rule books of the governance framework. Then if you are a workspace provider, you would provide those project workspaces, you would sign a workspace provider agreement, and you would agree to the rules and the requirements specifications set for that particular role and the generic ones. So the ecosystem members sign their own contractual agreements and become liable for the requirements and the liabilities that are set in those. And all members can participate in the governance development itself. So we want to make sure that the members have the possibility to participate. But the decision process, they are made only by the full ecosystem members. So essentially, the hospitals, at least at first, the hospitals are the primary ecosystem members, full ecosystem members, who would be making the decisions on the decision boards. And the rule books itself, they define those commonly agreed requirements, policies, and refer to any implementation specifications that enable interoperability of systems. Then let's look more about how the PHDS works. So this is, again, a high-level picture. We cannot go into too much details yet. I know there's a lot of complexities behind these steps, but I'll try to explain as simply as possible. So you can see, again, on the left side, we have the research team and the project workspace. And on the right side, we have hospital environments. For example, Finnish hospital, the HUS, or Erasmus from Netherlands, and UK GOSH here. And we have in the middle, we have shared services. And shared services, like I said, they are common services provided by the governance entity or a party that they contract to run these systems. And the purpose of the shared services is to enable lower threshold for entering and joining, and also facilitate trust in this whole ecosystem. And so these are services that we see that they enable scalability, they enable security in the sense that these are certain things that we can control by the governance entity and collectively, but they also enable so that when you join as a party, whether it's as a workspace provider or as a hospital, you don't need to do everything yourselves, because there's no need. We have mutual trust because of our mutual goals, but we have mutual trust because of the contract and governance model. So we can trust certain things to be done by shared services, and also that we can trust that workspace providers do their own requirements and hospitals do their own as well. So here, the data availability step starts. It starts with the shared data catalog. And the shared data catalog is essentially, like I said, it's an OMAP-based data catalog, which catalogs or collects the information provided by all participating hospitals, and it collects the metadata information. So it essentially reveals that what type of information each hospital is providing through this data space. So it doesn't reveal the data itself. It doesn't reveal any results. It just reveals to the researchers that this type of information is available through HUS, for example. And that data set may be a little bit different from what the Erasmus and GOSH are doing. So And if you scale this to tens hospitals or even over 100 hospitals, you can see that we need to somehow create a way to find that information. So the researcher uses the shared data catalog to create these kind of availability queries. What that means is that the researcher essentially creates what we call a cohort, a research cohort, and or they actually request from each hospital that I would like to use this kind of cohort to do my research. So essentially stating that certain patient filters and certain observational data points that they would wish to research. So for example, that I would like to research children between 10 and 12 years old, and I would want these data points regarding cardiac diseases or medicines they're using, etc. So these kinds of information they would want to know. And that availability query is then propagated using federated node, for example, to all of these hospitals that will hold that data. And this is one of those, so this is kind of the availability query is already something that is really valuable, that we could do that fast and also securely and privately without the ability to correlate information about using different queries. So each hospital would respond then with certain type of response, for example, that yeah, we have over 10 results, or no, we don't have results for these filters, etc. So it's really about collecting information about which hospitals would be participating in the research that you're doing as a researcher. And the project workspace provides tools to access these shared services. Once the availability is found, that you know what kind of query you can use or cohort you can use in the research, you would do then the data permit application. And you can see that for data exchange, we have selected now to use Git repositories. So if you know Git technology, so it's essentially a decentralized it started as a code management tool, but it's useful for any kind of data exchange or data management in this case. And we're planning to use GitHub at the moment, and the GitHub provides really nice tools for any kind of identity and access management, and also but also about revealing certain things only to those collaborators that you wish to reveal them. So what this means also is that we can use Git for any kind of data exchange between the research team and the selected hospitals that they want to participate with. For example, a data permit can be created so that they would create the data permit information, store it in the GitHub, the Git repository, and provide access then to all of the hospitals that have said that, yeah, we actually hold the data that you would like to use for your research. And then that permit process would be engaged by hospitals and by the research team using the Git repository, and any kind of changes or updates needed to do for the permits would be done through the Git. And what's beneficial for this is also that any changes that are done are traceable. So each change that happens to any of the documents, you know who did the change, and so you know if anything has been changed, that you can verify that. So that is very, very important in this case. And once the permit process is done, so each hospital approves that yes, we'll give you a data permit, then the federated data processing can happen. And how that works, and this is super, super simple and over high level now. The idea here is that you are able to either use your own algorithm, federated processing algorithm, or you can choose from a set of existing algorithms you would use for your research. And that algorithm is essentially packed into a container and stored here in the Git repository. And obviously the algorithms are something that need to be verified and approved by the hospitals before running. And then once that algorithm and the data permit are approved, each hospital then is able to utilize what's called the federated node. And what that means essentially is that each hospital holds their own node, and the federated node collects all the required things: the data permits, the algorithm, information about the project, who wants to run it, and all the cohorts, etc. And they run it in a sandbox that is provided by the hospital, and that is also maintained and overseen by the hospital. So this is hospital premises already, but it's used on a data or used on this kind of sandbox environment, so that it's limited to what it can do. It's limited to what data it can access. So it accesses data that is according to the OMOP data that in this case HUS has promised to share, and it runs the analytics query in all of these. So each federated node runs its own analytics query within the premises of the hospital, and these are isolated by themselves. So the actual processing happens on the hospital end, and once the results are verified, and in this case, the verification means, for example, things like making sure that the results are anonymous. You cannot identify any patients from there, and all of these kinds of things. These may be also very hospital specific on what type of verifications and validations need to be done before releasing. Only after the manual verifications, the hospital will be able to then release the information. Now you can see I've added here on number 4, the concatenation of results is something we're still working on. What's going to be the actual technical mechanism to do that? Because this is also a regulated area on what kind of information you're allowed and to where you're allowed to release the information. So we're still figuring out the details on how and where the results are released, whether it's through GitHub or whether it's directly to the workspaces, or whether there's some other proxy service to be used. But we're currently working on that. Issue at the moment. But in any case, the point there is that it's not automatic release of data, but it needs to be going through the steps of that particular hospital and their policies on what they want to verify before releasing it. Obviously, in the future, for certain cases that are on a very high trust level, for example, you would have a hospital employee making queries to another hospital, you would be possibly able to do much more automated releases of data, because there's understanding that this is a hospital employee working on a hospital case, and maybe there's another contract, so that it may be allowing different types of automated mechanisms for releasing. But those are more on the far future. So we want to, at first, we're trying to learn what is the comfort level each hospital is able to do. And that's roughly the basic features on how PHDS would work. And you can see that these are quite generic, actually. So there's quite a generic in terms of how do you discover data, and how do you exchange things like unsensitive data, like data permit applications, and how do you run a more sensitive process like the federated data processing, and then obviously then the automation factor of how would you release or verify the results, as well as verify that the permits are in order, that the identities are verified, etc. And that's the basic premise of that. So we still have a couple of things that I like to go through. One is sort of one of my favorite areas, which is the trust model. And there's also a lot of complexities behind this, but I want to make sure that you get the basic gist of it. The first thing on the trust layers is that we want to make sure that whoever is doing any requests or whoever is communicating in this, we want to make sure that they are members of the ecosystem. Because we want to make sure that the workspaces, the data controllers, they have an active agreement in place. So that means that they're liable for whatever happens for the data, for example, and for any type of actions. So we know that there's liability and promise that they are acting well. So for this, we would be using some type of ecosystem trust registry. The form during FEMS, it's going to be way simple. It's more or less going to be hard-coded initially. But once we start to scale, we need to consider different kinds of trust registry mechanisms for this. But it's the ecosystem governance entity essentially stating that which data controller, which workspace provider has an active role and active agreement. Secondly, the digital identities. Digital identities essentially trusting the researchers and trusting the projects that they're working on. And for that, we're using decentralized identifiers. So each researcher, each project would have their own digital identity, and they would be anchored by a workspace provider. Or actually, we're considering also even more open mechanisms, for example, that you would be able to use your own identity anchoring DID-based mechanism, if you're familiar with those, and provide sort of the identifiers to the ecosystem itself. But the point of this is more that it's uniquely identifiable, and there's a mechanism to verify your identity using those identifiers. So to actually verify the people, the identities of people, and also on the signatures, there's layer 3, signatures and credentials. So we are using verifiable credentials to prove a lot of things. We are using credentials to prove that a project has received data permit. We would be using also credentials to prove that who are these researchers, their personal identification data, for example. And you may have seen digital wallets, and you may have heard also about the EU digital identity wallet. So we're imagining and we're planning that you would be able to use as a researcher your free EU digital identity wallet to sign, in this case, the data permit application, for example. You would have a principal investigator signing the data permit application, because and that would be done using the EU digital identity wallet. The same way you would be providing credentials, identity credentials, to verify, according to the EIDAS regulation, who you actually are. And this is really, really critical for hospitals to understand that before they give permit, they know that who is asking this permit. So those information needs to actually happen decentrally, because they are not, it's going to be a challenge in scalability if you would require that they would need to authenticate at every data controller's premise before they can provide a data permit. So for this purpose, use of verifiable credentials, like, for example, person identification data, that would be EIDAS compliant EID, those are something that we will be utilizing here as well. And then layer 4, and that's more about the exchange data. It's more about then different kinds of data policies. So whenever results are being shared, and whenever there are different kinds of algorithms or models being used, we need to verify that where did these come from? Are these the same algorithms that we have already approved? You can remember the GitHub, for example, and the hashes on that we can pinpoint which algorithm and which version of the algorithm was actually approved by the data controller. So we can verify that this is exactly the same code base or code piece that we verified. Also, the result sets could be added with this kind of data policies. And what we mean by this is that there can be additional data policies for the research group, and that would be something that each data controller would be able to say that, hey, for our data, these are sort of the policies that we want to enforce when you use it, and you can use it with these kinds of things, but not these kinds of things, etc. So this is something that we're also looking into in this. And then lastly, about the business approach. So I was mentioning that the scalability and sustainability is really important. And we do envision that this is something that will enable new kinds of business for many of the organizations. So the pediatric health data space participants, for example, workspace providers, that's actually a very relatively new role here, is that there's a workspace provider that could serve independently researchers, like commercial researchers, universities, and other hospitals. So hospitals, obviously, in this case, could also be a workspace provider, so they can serve their local universities or even their own researchers that are working in their own premise. For example, for benchmarking purposes, like I mentioned, hospitals are really keen on finding new benchmarking opportunities and new ways of getting that benchmarking data. So you can imagine that a workspace provider is able to provide a system that large and small hospitals are able to access the pediatric health data space. So you would get access to benchmarking. Same thing for commercial research, technology providers providing new health technologies, biomedical companies, pharmaceutical companies, and R&D organizations interested in looking at this from commercial research perspective. That would be same thing for workspace providers. For non-commercial academic research, definitely fast and makes this research process a lot faster. So all of these parties can get new kinds of benefits, and wider impact, contributing to the long-term commercial and public impact of this. And you can imagine that the access to data is just the workspace provider viewpoint. So whenever you start to do then transactions, or in this case, for example, getting access to the data, running those algorithms, those will generate also revenue to the data controllers, because they will need to use also their resources to run the algorithms, and the access to this data space is actually quite valuable, because you will get access to information and the results much faster than you previously had done, with much less effort. And this is something we do see, that there's going to be a perpetual growth cycle once we get this up and running, is that everybody actually gets benefits, and that should be able to create a lot of interest, which in general creates new benefits and new revenue to everybody, etc. But that's the simple of it, if you will. So I feel that I just had the chance to scratch the surface of everything, not go too deep in anything, but yeah, maybe we can now start with any questions.
Thanks, Antti.